Very good morning, and my sincere apologies for not being able to be with you guys in person. Due to some emergency in family, I had to cancel my visit the last moment, and I sincerely apologize for that. The topic that has been given to me is that my patient with uveitis has positive IGRA. Do I treat it for TB or not? So let's look how do we answer this question. TB uveitis, as we all understand, is quantum in the uveitis field and mainly because the clinical phenotypes are very, very diverse. And the reason for such diversity is that uh, there is a hematological spread of Mycobacterium tuberculosis. The RPE, which is the retinal pigment epithelium phagocytosis, and orchestrates the immune response, which results in the development of the phenotype that is totally different from some other mechanisms. We also have elevated cytokines including IL-6, 10, CXCL9, VGF, FGF. There is formation of granulomas and there is autoreactive T cells. So, understandingly, when there are so many mechanisms which are playing a role, the clinical manifestations are going to be very diverse. And how do we test for TB? When we think of the direct evidence, like for pulmonary TB, including smears and cultures, we all understand that it's not possible due to several limitations. So what we are left with immunological test, which mostly the Montes is the one which is commonly performed in endemic and IGRA in non-endemic countries. We also have a radiologic evidence which invariably will not show an active disease. It just indicates that, well, there has been some exposure to TB in the past, which may be seen like calcified lymph nodes, hilar, or some telltale evidence that the patient has been exposed to the infection. But when we talk of the ocular TB, this radiologic evidence is invariably interpreted along with the immunological test and not a standalone test. So we come back to our major question that my patient has uveitis and IGRA comes positive. Could it be TB? So let's look what TB can produce in the eye. It produces certain very, very classical phenotypes, which over a period of years, we know that these phenotypes have a very high probability of having TB as an underlying etiology. So we will call these phenotypes as horses. But we also have zebras, which means we say that TB is a great mimicker and it can produce anything, any manifestations in the eye that could resemble any form of uveitis. So we call those phenotypes as zebras. So let's look at the horses because more commonly it's the classical phenotype which are going to present, and zebras, believe me, are not so common. So what are the typical phenotypes horses for ocular TB? Now the first and the foremost is granulomatous interior uveitis. You have these mutton fat capies, you have these nodules which could be on the border or it could be on the surface of the iris stroma, like we call them Visaka's nodules. So there is no doubt that this patient has granulomatous interior uveitis. And here is an example of a typical Kopis nodule on the margin of the iris. Or you may have the patient who has broad-based posterior synecdoche, and here you see a triangle which has a very broad base. So some of these manifestations are likely to be TB. So get tested for TB. If IGRA is positive, think of TB as an etiology. We come to another situation of anterior uveitis, a 42-year-old man, sudden decreased vision, and it is severe, acute. The patient remembers exactly the time when it started. When you look at it, there is fibrin, there is non-granulomatous kind of uveitis, and there is some hypopyon. So it's an acute non-granulomatous anterior uveitis. This is very classical for non-TB. So do not even think of TB because this is not suggestive of TB. So even if, like firstly, I would not even get it tested for IGRA, but if for whatever reasons you have got IGRA done, please don't pay attention to it because this patient does not merit treatment with ATT. So that becomes a classical non-TB horse, like it's just not TB. Then we come to anterior uveitis zebras, like you are not sure, it could or could not be TB. So this is a patient, you see hypopyon uveitis in a pseudophakic patient, but it's a very chronic, low-grade kind of inflammation, and it has a kind of a granuloma on UPM, which you see in the ciliary body, and the granuloma has a hyperdense center. So this patient actually underwent surgery because there were peripheral exudates and we were not sure what we were dealing with. And when we did the vitrectomy, the TAP was positive for TB, and this is how the patient responded. So these zebras are actually not very classical phenotypes. They are atypical. So in such situation, you could pay attention to positive test like IGRA in this instance. From anterior, let's move on to intermediate uveitis. Intermediate uveitis, to be very honest with you all, does not have any specific biomarkers for TB. Though we have not really said it in so many words, but in my personal experience, if you are seeing a patient of intermediate uveitis, which has large snowballs, kind of hanging in there in the inferior vitreous, but they are not forming snow banking. There is no fibrosis, no banking that you see typically in patients with pars planitis. TB could be a possible etiology. So, and intermediate uveitis having TB as an etiology is honestly not very common, and the response to anti-TB is not very great. So any patient with intermediate uveitis, if you have IGRA positive, don't jump on to treating straight away because it could just be an incidental positive IGRA. Moving on to the posterior segment now, like choroid. Choroid has some very well-defined typical manifestations are horses, and one of the typical one is choroidal tubercles. Or you may see a large tubercle forming a kind of a tuberculoma. Now, these are the manifestations where you see, well, it's there, looks like TB, IGRA is positive, well, I would treat it with anti-TB drugs. Now, let's see what could be zebras in the choroid. A large tuberculoma which mimics an abscess. This is a zebra because though it could be TB, but still it could still be metastasis, it could still be fungal. So you will have to rule out all other possible etiologies before believing it to be TB. Another zebra that we encounter in our choroid all the time is we are confused sometimes between TB versus sarcoid granule. Now, this top one is how TB granulomas look, whereas the bottom one is sarcoid granuloma. We did publish recently about how to differentiate between TB and sarcoid granulomas. TB granulomas tend to be large, sorry about this, tend to be large, whereas the sarcoid granulomas are multiple and they are in the stroma and they're not very visible on your face like TB granuloma is. When we do OCT, this is the large TB granuloma, which does show changes in the outer retina. In contrast, the sarcoid granulomas are multiple, embedded in the stroma, and you don't have too many changes in the overlying outer retina. TB granulomas also tend to have vascularity to them because they are dependent on VEGF. So you may see lesions of RAP or some vascularity on the surface of TB granuloma. For example, if we notice here, these two have vascularity in TB granulomas compared to sarcoid. Another horse, the horse, is serpiginous-like choroiditis. Like serpiginous-like choroiditis, when we see, and it's important to differentiate it from a non-horse, which is an autoimmune variety of serpiginous choroiditis. And how to differentiate? The autoimmune serpiginous choroiditis tends to be bilateral, whereas TB tends to be unilateral. Serpiginous has absent vitreous or anterior segment inflammation, whereas TB may have inflammation in the vitreous or in the anterior segment. Serpiginous typically begins in juxtapapillary area compared to TB in the posterior pole, and very important is the multifocality of lesions in TB, whereas typical serpiginous is not multifocal. Again, when we look at this serpiginous, the pigment clumping is at the border of the healed lesion compared to TB, where pigment clumping is at the center of the healed lesions. So from choroid, let's now move on to the retinal vessels. Occlusive retinal vasculitis. This is a typical horse for TB. This is how you would see it. Angiogram shows typical areas of capillary non-perfusion. There may be new vascularization on the disc, or more commonly at the border of the perfused and non-perfused retina. So these are the patients. If IGRA is positive, you would definitely think of TB as an etiology because the phenotype is very characteristic. For this patient, the TB tests were positive, and when we did the EBUS, actually, it had granulomas with necrosis in the lymph nodes, which were seen on CT scan. The other phenotype is you have occlusive retinal vasculitis, and you also have choroiditis patches associated with a straightaway horse for TB, and the test positive. Always consider it positive and treat for anti-TB treatment. Now, this is a very typical, as if you see here, vasculitis and the choroiditis patch, which is paravenous in location. This is the angiogram of the same patient. You can see the non-occlusion, the choroiditis patches, and of course, this test was positive for TB. Those serpiginous choroiditis, retinal vasculitis, and tuberculomas in the posterior segment are straightaway horses for TB. Multifocal choroiditis is more like zebra because it tends to be non-TB most of the time. But very rarely you may actually have TB as an etiology. And I'll show you an example of one such lady, a 57-year-old. She had trauma to the opposite eye and she presented to us like this. And we thought of sympathetic ophthalmia because the phenotype was not suggestive of TB. There was some peripapillary serous detachment, something happening in the periphery, which, to be very honest, we could not pinpoint what it was. So we diagnosed as sympathetic, give steroids, and the investigations were very unequivocal. Neither the IGRA nor the PPD skin test showed any evidence. While on the treatment with steroid and immunosuppression, the lady continued to progress. Now, this is what I want to highlight, that if the patient is not responding the way you would want patient to respond, it think of TB at that particular point of time. So we again repeated the test, nothing positive. We did the enucleation of the blind eye, and we did see a single AFP positive bacillus sitting there. And of course, this patient subsequently treated and responded to anti-TB drug. So to summarize, if the phenotype is classic for TB, could be TB, treated, tested. If the phenotype is classic for non-TB, do not pay any attention to the test for TB. If the phenotype is gray, which means you are not very sure what it is, rule out other possible etiologies and think of TB, because TB is a great mimicker and can have protein manifestation, though it's not very common for TB to have atypical presentations. Now, what will happen if you fail to recognize the phenotype? For example, this is a patient, and this is classically multifocal serpiginoid choroiditis, but somehow TB was not thought of as the differential diagnosis, and patient was treated with steroids, and this is what the opposite eye was at the time of presentation. This was done outside. So PPD was 12 by 12 and quantiferon gold was not even done. Patient was given oral steroids and she did respond initially to steroids, but then lost to follow-up. And when she came back, you can realize the good eye has developed a full-fledged abscess and granuloma, and you can see the vascularity. So now she is treated with the anti-TB drug. TB gold was positive when we repeated it, and she started responding to therapy with anti-TB drugs. So the next part of my talk will be, well, your IGRA is positive, but still, whom would you like to treat? Because the IGRA positivity does not mean that you start treating everybody. So if the tests are positive, does it become ocular TB? Should we treat all the patients who have a positive IGRA? It's very important to understand the pre and post-test probability of the test for TB. And we also have a problem because many times our ID experts refuse to treat TB with TB medications. So to answer this question, I will briefly go over the guidelines of CORPS supported by IUSG, IOIS, and Foster Ocular Immunology Society. So this was a consensus document, statement, white paper which we had, depending on what was the phenotypic presentation, which country the patient belonged to, what was the first or the recurrent episode, whether the disease was active, inactive, and 3 tests we considered: IGRA, PPT, and chest X-ray or CT chest. And the rest of the questions were designed on the various permutations and combination of these. The experts after the consensus or during the consensus agreed that most important step towards the treatment is recognizing the phenotype, which I have already discussed. And more specific, the phenotype for TB, stronger the consensus to treat with anti-TB therapy. For example, serpiginous-like choroiditis, the horse for TB. So experts will treat even if only IGRA is positive. Experts would be very happy to treat if all the 3 tests were positive, if PPT and IGRA are positive, if only PPT is positive, or even if only IGRA is positive, because this phenotype is very well suggestive that the underlying etiology could be TB. So this is just the what I have said, that the immunological test, even if single test, and because this topic I'm dealing mainly with IGRA, So if you have this presentation, IGRA positive, please go ahead and treat it. One thing to keep in mind, this is an immune-mediated response because of the RPE playing a major role here. And we have to understand that when you start with ATT, like on the top, there are a lot of patients, almost more than close to 50%, who are going to have some form of paradoxical worsening, which could be either the increase in the size of the original lesions, as you can see with the black arrows, or the development of new lesions like you see white arrowhead in the periphery at the bottom. So there was a consensus about the concomitant use of corticosteroids to prevent paradoxical worsening after the initiation of ATT. In patients where we are unable to wean off the steroids or in whom the disease progresses despite initiation of ATT, corticosteroid sparing immunosuppression may be added. And this is an example of choroiditis other than serpiginous-like choroiditis. And for other choroiditis form for tuberculoma, we had a good consensus to treat. So even if one test is positive, you would treat. For multifocal choroiditis, as I mentioned previously, there is no strong consensus to treat because it's one of these IGRA. It's more likely to be autoimmune than TB. So be cautious when you are treating some of these phenotypes. Acute anterior uveitis, the experts agreed to treat only if the disease was recurrent and 2 or 3 tests are positive. So single IGRA positivity you may not treat. Intermediate uveitis, again, single test you would not treat. Retinal vasculitis is again to be treated if 2 or more tests are positive and only when the disease is active. There is no need to treat inactive vasculitis if only IGRA is positive. The more details of this are available in our consensus and more recently published COTS calculator, which is available on our website and IUSU website as well. You simply enter very basic information about the name, ID, gender, country. When you enter the country, it will show you, what is the endemicity of TB in that country. And we again rely only on 3 tests: TB, interferon, chest, or CT imaging. When you enter, the calculator itself is going to tell you the results based on the COTS consensus. For example, this patient which we entered was serpiginoid choroiditis from an endemic country, positive TB test and chest X-ray showing positive, and when we press calculate, it says there is a very high probability amongst experts, which means more than 90%, would consider initiating anti-TB therapy. So, coming to my last slide, and the question posed to me, my patient with uveitis is positive IGRA. Do I treat for TB or not? Treat only if the phenotype is suggestive of TB. Treat only if all other differentials have been ruled out and you strongly feel that ocular manifestation is related to TB. If you are not sure, don't treat in the first episode because you could always add ATT at a later stage because this is not an infective disease process in majority of the time. So most of the phenotypes are immunological manifestation. So you treat it with non-TB standard of care therapy. And if the patient continues to have recurrences, you can always add ATT at a later stage. I hope I'm able to answer this question. And with this, I would like to thank Rupesh, Peter, Justin, Lyndall, and all my colleagues there for giving me this opportunity. And I do hope I'm able to answer some of these questions which was posed to me. Thank you very much.